my talk will be about a tool for observing your residents and providing them with feedback. It's called the tool is called the Ophthalmic Clinical Evaluation Exercise, or OCEX, and Mina mentioned it as a tool for providing formative feedback. And as Mina already discussed, the traditional assessment is the assessment of medical knowledge, where students are assessed mostly on what they learn in the class or mostly on what they learn in books or in papers. But in the health professions, it's becoming more and more important and more enforced, the fact that we need to assess them in what are called as authentic assessments. This means that residents need to be assessed in what they are able to do outside of the classroom. And this means with patients in the real life. As Mina already mentioned, the pyramid of Miller, workplace-based assessments assess exactly that, assess students on what they are able to do, not only on what they know theoretically, but on what they are able to do. There are several tools for workplace-based assessment. The most well-known is the Mini Clinical Evaluation Exercise, or Mini CEX, and in ophthalmology, it has been adapted to the OCEX. But also we have multi-source feedback, or 360-degree assessments, directly observed procedural skills, audits of medical records, and significant event analysis. This talk will be about the OCEX, the Ophthalmic Clinical Evaluation Exercise. So the objective of this presentation will be that by the end of it, you will be able to use the Ophthalmic Clinical Evaluation Exercise to assess your residents' performance with a patient and to provide them with formative feedback. The Ophthalmic Clinical Evaluation Exercise was developed by Golnick and collaborators in 2004, and it was validated, and its reliability was determined in a later publication in 2005. It consists of the assessment of several aspects of the medical consultation of a resident with a patient. It has a part for assessing interviewing skills. So here you can see that the observer will assess the resident on how they introduce themselves, if they obtain the chief complaint, the history of present illness, the allergies, review of systems, etc. Then there is a second part for assessing the examination skills. So if they assess the best corrected visual acuity, pupils, motility, external, fundoscopy, etc. Then there is a part for assessing interpersonal skills and professionalism. So the observer will check if the resident is being empathetic, respectful, and courteous, if he explains findings, if he asks if the patient has questions, etc. And the last part is about case presentation. So how the resident presents the case to the attending doctor, if he's concise and clear, if they present the pertinent facts, the appropriate plan, etc. The tool comes with a scoring rubric that consists of 4 columns, where the resident is assessed if he meets the expectations, if he meets some of the expectations, if he meets all the expectations, or if they exceed the expectations. And each of these come with a descriptor. For example, for the chief complaint, if the resident does not elicit the chief complaint, they will get does not meet grading, does not meet the expectations. If they elicit some but lack some details, they will achieve meet some expectations. If they elicit the whole chief complaint and get some details, they will get meets all the expectation, and if they elicit concisely and efficiently, they will exceed the expectations. So this is how it is carried on. The resident is having a regular consultation with the patient, and the observer is there watching to what the resident is doing. I will now show you a video, and we will practice on how to use the OCEX for observing a resident who is assessing the patient's pupils. So I will show you the video in a minute, but let me please explain this first. You will receive the scoring rubric, and you will see that if the resident does not check the pupils, you will have to assign him 1. If they check the light reaction but does not do the swinging light test, they will get a 2 or meet some expectations. If they check the light reaction and they look for the relative afferent pupillary defect, you will assign them with a 3. And if they do additional and appropriate testing relevant to the patient's history and exam, they will get an exceeding expectation or a 4. So let me show you the video, and then Eduardo will pop up the questions. So here is the resident, and he's checking on the patient's pupils. Okay, so Eduardo, would you please pop up the questions? I will show the video again.
Okay.
Oh,
the questions are on screen.
do we have the answers already?
Yes, the most chosen answer is meets all the expectations. After that, meets some expectations, and after that, does not meet expectations. Only 1 out of 13 chose this last one.
Okay, thank you. Would you close the box for me, please?
Sure.
Thank you. So yes, probably both are correct, number 2 and number 3, because the resident actually checks the light reaction. But what is wrong here is the technique, because the patient should be looking forward to a point in the wall, and he didn't tell the patient to do that. So this was a criticism of, and I'm going to discuss this later, this was a criticism of this tool, that it does not contemplate every aspect of the consultation. And we tried to improve that with a second version of the tool. So the OCEX has some advantages. It is practical and fast. It is valid and reliable. It is inexpensive. You can do it in your consultation just with the patient and the resident and a form, a printed form. And it's a systematic way of having, of evaluating the resident, of assessing the resident. And also you can keep it as a document, as an assessment document for the future. It has some limitations though. Some question if it's really an authentic tool, because the resident will behave differently if you as are observing them performing with the patient. Probably they will be extra empathetic or extra nice to the patients. But anyway, it's what we have, and it's a good way of giving them feedback and of letting them know what we are really expecting from them regarding professionalism and regarding communication skills. The other thing, as I said, is it does not address every possible situation. Anyway, it comes with, the form comes with a space for observations. So if you have something extra that you'd like to tell the resident, you can write it down there. So in your setting, what do you think would be the main limitation for implementing this tool? This is a list of limitations, of possible problems that, that you may face if you try to implement this. Please select the one that you think is going to be the main one. That residents are not really authentic when being observed, that patients would refuse to have an observer faculty during the consultation, that faculty has no time to spend on this kind of assessment, or that they will not understand the need for this kind of assessment, or other. Eduardo, do we have answers?
Yes, we have several answers now. Okay, I'm going to stop the call and share the results.
So, that residents are not really authentic when being observed. That's the most popular one, right?
Yes.
Okay. Yes, as I said before, they are not really authentic in that, maybe in empathy or in how they treat patients, but they will be authentic on the rest of the skills. If you're watching them, I don't know, measure the intraocular pressure, for example, that's something that they will do as they know to do it. So that's an authentic way of observing how well they are performing in that aspect. So maybe for professionalism or communication skills or more soft aspects of competency, this is not a really authentic tool. But for the rest of the aspects, like how they take the medical records, how they examine the patient, how they present the case, that would be an authentic way of assessing that. I will let you know how we do it in my program, so you can find some ideas on how to do it and how to convince your faculty that this is not something that takes a lot of time, and it is not something that it's expensive to do or impossible to do. So for implementing the OCEX, it's important that to remember that it's a formative evaluation. So residents need to receive feedback, at least 5 minutes of feedback on letting them know how they are doing things and what they need to correct. It's important to, or at least we do it during the rotation. Our rotations last for 4 months each. So if they do it in the middle of the rotation, they will have 2 months extra to improve on what they were being told. We usually do it with first-time patients because they are more rich. You have more things to evaluate. Control something come for 5 minutes or 10 minutes, and it's more difficult to assess residents on controls. So we usually do it with first-time patients, and the consultation shouldn't last more than 15 to 20 minutes. We do it at the end of the day, so if they need extra time, they can take a little extra time, but it should take the time of the usual consultation. And we usually do it with 2 patients per resident. So after 15 years of having used this tool, we decided that it was time to review it, and we wanted to validate it for international use. We were all working with the International Council of Ophthalmology at the time, so we needed to, or we wanted to validate it for international use. We kept the same methods, that we kept the same aspect of the consultation, that were in the original OCEX, interview skills, examination, interpersonal skills and professionalism, and case presentation. But what we do was we try to improve the scoring rubric. So instead of the does not meet some expectations, meet some, meet all, or exceeds the expectations, we transformed it into Dreyfus-based rubric. So we had the novice, the beginner, and the competent resident, and we tried to improve all of the descriptors as well. Because one of the things that were criticized about the original OCEX is that interpretation to the grading scores was very variable, which made the inter-rater reliability low. So with this Dreyfus scale that put more emphasis on performance and progression, we tried to improve this variability in interpretations to grading scores. We also simplified the scale for feedback. Instead of 4 grades, we decided to have 3. And we modified it for global use, especially regarding professionalism and communication skills. We sent it to a panel of international professors, and they provided their feedback regarding to their regions of the world about the appropriateness of the professionalism and communication skills evaluation. And we called it the International Council of Ophthalmology Ophthalmic Clinical Evaluation Exercise, or the ICO OCEX. And we published it in the Indian Journal of Ophthalmology in 2021. The thing with this is that we left the ICO at the time, and the tool was not validated to our knowledge. So in conclusion, the OCEX is a workplace-based assessment tool of competence. It allows to observe multiple aspects of the consultation and also to correct the resident and provide them with formative feedback. And this is an important thing to do. I remember once I had a resident that he was an advanced first-year resident, and he was seeing patients with me, and I asked him to check my patient's intraocular pressure. And all my patients had high intraocular pressure, and I was wondering why this happened, because I mean, I have seen these patients less than a year before and they were okay, and now with this resident they all had their intraocular pressure high. And the problem was that nobody had checked on how this resident was measuring the intraocular pressure. So his technique was not appropriate, and all the patients came with high intraocular pressure. And that was only because no one had checked on him on how he was checking the intraocular pressure.